Module 1, Perioperative Nursing. A reminder that perioperative refers to all phases of the surgical experience, including pre-op, intra-op, and post-op. This lecture will cover the preoperative phase. So we will be focusing on priorities for the preoperative patient. We begin by going over what a pre-op nurse is responsible for. So as a preoperative nurse, you are an educator, an advocator, and an admitting nurse. So as an educator, you are responsible for explaining to the patient what is going to happen. This is a very important component of the pre-op nurse because patients are scared, they're worried, and many patients at that point have never been to a hospital before, so that educator role is very important. You are also an advocator. You are advocating for the patient to make sure that they are safe and they are well informed prior to their surgical experience. And then, of course, you are an admitting nurse. So as the pre-op nurse, you are receiving a new patient, and there are many things that need to be done, including a health assessment, a physical assessment, pre-surgical prep, and lots of other things. So to make your life easier, you are going to complete a preoperative checklist that encompasses all of those things to make it easier to just check it off to see what's missing to ensure that the patient is going to have a safe experience. The pre-op checklist will vary by facility depending on how big the facility is, what resources they have, what they require, what type of surgery the patient is going to have. Is it a small surgical procedure or is it a very big surgery? The checklist will be fit for whatever the patient's going to have. These standardized checklists, or any standardized tool, facilitate communication, they reduce errors, and they make the process streamlined. So it's very easy to see what the patient is missing so you can get that done so the patient can move on to the next area. This will also identify potential issues before surgery. So if the patient took a specific medication or they didn't get a certain medication, this will alert the staff and ultimately the surgeon on a potential problem that can interfere with that surgery happening that day. Overall, this checklist is going to ensure that all procedures are performed in a timely and safe manner. This is just a small picture, a little cartoon picture that shows you some of the things that can be included in a pre-op checklist. You can read through them on your own. Just to name a few, we have informed consent signed, patient is NPO, they completed a bowel prep, patient voided prior to transfer, pre-op meds given and charted, dentures, eyeglasses have been removed, medications have been documented, including in their MAR in the chart, and high alert medications have been noted. So those are just a few things that could be on a pre-op checklist. Overall, documentation, assessment, physical preparation, and any educational needs the patient requires should be documented on that pre-op checklist. Next, we have informed consent. So informed consent is when a patient autonomously and cognitively grants permission to a provider to perform a surgical procedure after considering all alternatives, benefits, and risks of the procedure. So this is a responsibility of the surgeon to obtain informed consent from the patient. You as the RN are not required or allowed by law to be involved in having this discussion with the patient, but it is your responsibility to make sure the patient has received all the information needed to make an informed decision. So for example, if a surgeon comes in and is speaking to the patient in the pre-op area and you are the nurse witnessing this conversation and the surgeon doesn't really give a lot of information to the patient and says, okay, surgery is going to go well, please sign here. And the patient, signs. It is your responsibility as a nurse to ask the patient, are you comfortable? Do you understand what's going to happen? Did the doctor explain, the risks and benefits to this? Are you okay to sign? So you are advocating for the patient to make sure that they really truly have been informed of all of those things that are in an informed consent that we'll talk about next. So again, it is the surgeon's responsibility to do this, not the nurse. Your responsibility is to make sure that it was done and that you advocate for the patient to make sure that they truly do understand what is going to happen. So when a patient has information, has been educated, and is, quote, informed, they're more likely to cooperate with the plan of care. And this actually is the same when you're working with patients in general. When you have the information and you understand what's going to happen from start to finish and you understand why things are going to be done, then you are going to be more at ease, you're going to have less anxiety, and you're going to be more willing to do the things that we ask you to do. So if we tell you, um, and this kind of overlaps with educating a patient and explaining, if you tell them, when you wake up from surgery, we're going to give you this incentive spirometer because this is going to prevent you from getting pneumonia after your surgery, then they understand the reason why you're going to be asking them to do that. So when they wake up out of anesthesia and you're handing them an incentive spirometer, they're not going to fight you. Well, they still might fight you, but they're going to be more willing to do that intervention. So it is the same idea. The more information, the more informed a patient is, the better outcome there will be. And this is evidence-based. This is research-based. So it's not just something we think. This is true. So back to informed consent. So components that should be included in an informed consent, and again, this is standardized. This is a standardized document. You're going to consent for whatever procedure they're having. The names of the surgeon will be included. Reason for intervention, so why are they doing this and why should the patient have this procedure done? Any alternatives if surgery is not the only option. Consent for anesthesia, sometimes this is a separate document, and consent to administer blood products. Now that is not always on the informed consent because not all surgeries have a high risk of needing blood. So if you are signing consent to have a lesion removed from your arm and you're going into a surgical suite, it is very unlikely you're going to need a blood transfusion. So they're not going to ask you to consent to blood products. But if you're going in for a major surgery, a very vascular surgery, yes, then that might be a component that they will ask. Next, we're going to talk a little bit about advance directives. We're not going to go into too much detail, but it is important when you're working in the perioperative area that you know if the patient has an advance directive. So in 1991, there was a Patient Self-Determination Act passed that gave the patient the right to make their own decision on what to do in a medical emergency. So before 1991, it was kind of left up in the air. The doctors decided what was best for the patient, or maybe the family member, or the friend, or the random visitor that was in the room. So there was no guideline. So now we try and have that patient, while they are still competent to be able to make that decision, tell us before something happens so that we can follow the patient's wishes. So a couple situations where this would be used would be during surgery when the patient is under anesthesia and something happens and a decision needs to be made. They can tell you beforehand what they want to be done. Or maybe the patient has already completed the surgery and now they are post-op and maybe there was some type of complication and they are not able to tell you, what they want because they are maybe still unconscious. So that would be another reason why we would want that advance directive present. So there is no question what the patient would want for their own medical care. There is also something called a power of attorney. So this does involve an attorney. So they are present and they help to write this legal document of the patient's wishes. So there are several different types of advance directives, and although this is not required for a patient to have, it is a requirement of the hospital to ask the patient if they would like to set one up before the procedure. And this is typically done when the patient is registering into the hospital. But this is also something that you check in the chart to see if it's present, because if there is one, then we want to let all the staff know and the surgeon what the patient's wishes are prior to the procedure. Moving on to patient assessment. So the next couple of slides are just the bullet points, and then we are going to go through each bullet point to discuss the significance of asking these questions of the patient assessment. We're going to start with medical history. So we want a full medical history, including any chronic conditions the patient may have. Now, if you look at this picture, you might have seen this in the past. Maybe if you were a patient at your doctor's office or you're with somebody else at the doctor's office, we have a couple pages where you would check off, have you ever this? Have you had this? Do you have history of this? Does a family member have history of this? Now, this can be done before some surgical procedures depending on the surgery. So if you have a surgery that is elective, meaning that it has been scheduled, so maybe it was scheduled a week in advance, a month in advance even, then we have a lot of time to do this beforehand. Sometimes this is done during the consultation of this, of the surgery in the doctor's office. If when we have an elective surgery, we try to do all of the preoperative documentation as much as we can before the surgery date. It just makes sense that way to catch things beforehand. But, most of the time these surgeries are not elective or maybe we just have a day in advance, or maybe the patient's already in the hospital. So those are just a few different situations where you might do this assessment a little differently, but we still need that full medical history of all of those chronic conditions. So why do chronic conditions matter? Well, some of them won't impact the surgery, but some of them will. So for example, if the patient already has a history of DVT, which is deep vein thrombosis, then we might pay a little more attention to some lab work prior to that surgery, or maybe the patient shouldn't have certain interventions done prior to surgery relating to that DVT. Or maybe the patient has some kind of heart condition already, or a lung condition, some type of respiratory condition like COPD or asthma. So that just means that we need to pay extra attention to that body system. So full medical history, especially those chronic conditions, are very important preoperatively. Allergies. So we ask allergies, or we should be asking what the patient's allergies are, if any, every time we assess our patient, whether it's in the hospital, in the inpatient setting, in the outpatient setting, we ask about allergies. So why is this significant preoperatively? Well, in the surgical area, in the operating room, there are lots of things that are routinely used that could pose an allergy risk. So like the betadine, surgical tape, certain gloves, latex, stuff like that. So we know that's going to be present. We just want to double check that those allergies are not present. So when you ask a patient about their allergies, always be very specific. Do you have any allergies to medication? Do you have any allergies to food? Have you ever experienced any adverse effect with the tape that we use? Give them example. You have an IV here. Have you ever gotten any rash from that adhesive? So be very specific, because patients, first of all, are anxious before surgery. They may not be thinking straight, and they may not really understand what you're asking them. So you want to get a really good allergy assessment. Surgical and anesthesia history. So have they ever had a surgery before? What was their experience, not only to the anesthesia, but to the actual wound healing of whatever surgery they had. These can be early indicators of a potential complication, and the surgeon will need to know that. Medication, so very important. So we want to get a good list of what the patient takes at home. This is going to include any type of medication, so prescription medication, over-the-counter medication such as like Tylenol, ibuprofen that they could buy themselves, any kind of supplements. The reason why we ask for supplements is because they can interfere and interact with other medications given. So very important that we are talking in layman's terms, and we are using words that the patient understands, because we really want that correct, accurate information. If you look at this slide, you see I have some certain medications pictured here. So starting with the first picture, anticoagulants. So generally speaking, anticoagulants should be stopped about 48 hours before a surgery. Now this is textbook. This is just generalized. Of course, when you get into practice and you start working somewhere, you're going to follow your facility protocol or your physician preference. Okay, but for us, we are going to say about 48 hours prior to surgery, any anticoagulants need to be stopped. And this makes sense because we don't want the patient to easily bleed or hemorrhage during the surgery. And very important, you should be familiar with anticoagulant names. The next set of pictures here are metoprolol and digoxin. These are both cardiac medications. So do we want the patient, or should the patient, stop these medications prior to surgery? Again, we are talking generally speaking. No, they should not be stopped, because this is keeping them at their baseline. So For example, metoprolol can affect blood pressure, but it also affects heart rate. And if the patient is taking these to maintain a within normal range blood pressure and heart rate, we don't want them to hold it, and then when they come in to the pre-op area, now they are abnormal and maybe they're tachycardic and maybe hypertensive. So we want them to continue any type of cardiac meds, any kind of antiarrhythmic medications. They should also continue to take those. Next, I have pictured some supplements, ginkgo biloba and turmeric. Those are just two examples of known supplements that interact with other medications. And these two interact with anticoagulants. They actually can make you bleed longer when you're on an anticoagulant, but there are many, many others. You won't be tested on specific ones and what they do. Just know we need to document any type of herbal medications and make sure the patient knows why we are asking that. And then our last picture here is of insulin. So insulin is a high alert medication, meaning that if you don't follow those 5, 6, 10 rights, you can cause harm to the patient. So we know we have short acting, we have long acting insulin. So it's really important that we ask the patient, are you on insulin and when was the last time you took this medication? So certain types of situations and also dependent on the surgeon will determine whether the patient should take their insulin. Because remember, the patient is NPO for surgical procedures, meaning that they should not be eating or drinking anything prior. So they should not be taking short-acting insulin. We give short-acting insulin usually with food as a bolus. So if they're not eating, it's very unlikely the surgeon is going to tell them to take their short-acting insulin. However, their long-acting insulin is a basal insulin and there is no peak. It kind of works, at least 12 hours up to 24 hours to kind of hold steady in the background. It mimics our normal basal insulin in our bodies. And for certain patients, they may take that basal insulin. They may not be asked to hold it, especially type 1 diabetics. Okay, so for our purposes, you just need to know we need to check insulin, we need to check anticoagulants, and any type of cardiac medications to determine when the last time they took it and whether they should have held it or not. Last oral intake. So as I just mentioned, patients should be NPO or nothing by mouth for a certain amount of time prior to their surgical procedure. This is the amount of hours is going to depend on the facility, the population, and what type of procedure they're having. So if they're going to have a really long procedure where they're going to be intubated under anesthesia, then we definitely don't want anything in their stomach. This is often communicated by saying nothing to eat or drink after midnight, but for our purposes, for textbook purposes, we are going to say 6 to 8 hours. Now you're not going to be tested on certain amount of hours, but you do need to know the concept that the patient should have an empty stomach prior to being sedated. And the reason for this is that when you have stuff in your stomach, whether it's liquid or food, you are at higher risk for aspiration when you are sedated. So under anesthesia, your body systems will slow down. They kind of go to sleep too. So this also includes your GI system. If you have food or liquid in your stomach and your GI system essentially goes to sleep, then you might become nauseous. And when you become nauseous, that may lead to vomiting. If you vomit while you are under anesthesia, those food particles can end up in your lungs and that increases your risk for aspiration. So you follow your facility guidelines. We're going to go with 6 to 8 hours prior to a surgical procedure. You should be NPO. Alcohol, smoking, and drug use. So during our pre-op assessment, when we're asking patients, do you drink alcohol? When was the last time? Do you smoke cigarettes? When was the last time? And do you do any illicit drugs? What do you do and when was the last time? We want to obtain accurate information because all of these things can affect the surgical experience. Hopefully this was asked prior and the patient is aware of how important it is to stop these activities before surgery. So alcohol and drug use, that can really affect the amount of anesthesia that is required to sedate a patient. And smoking can actually lead to a lot of respiratory complications and the ability of the patient to breathe on their own after surgery. So obtaining this information is vital, and you don't want to demean the patient if they did these things, because we want to build a trusting rapport with these patients so that they will give us truthful information. Oh, and I forgot to mention with the last oral intake. So for patients that actually do need to take their medication in the morning, usually it is okay for them to have a sip of water with their medication. So if the patient has taken more than a sip of water, or maybe they took a sip of water very close to the start time of their surgery, then that's something that you will want to let the physician know. I say physician because it could be the anesthesiologist and or the surgeon that you should tell, but you should definitely let the physician know if that's the case. Normally, when they take a sip of water with their meds, it's not right before the surgery, it is a couple hours before the surgery, and that's usually okay. But we don't make that decision. When in doubt, you will let the physician know, and they will decide whether that surgery needs to be delayed or canceled. Height and weight. We need an accurate height and weight to make sure that anesthesia doses are accurate, or any other type of medications that require an accurate dosing, like antibiotics sometimes. Patients who are obese or have a higher BMI may also need special equipment. So if you have a very obese patient, you may need a special bed or special equipment in the operating room to position them correctly. So this just gives everybody a heads up. Vital signs, we want to make sure we know that baseline vital signs, the blood pressure, respirations, pulse, temperature, all of those things. We should make sure that they are stable prior. And of course, our systems assessment. So this is a head to toe. We're going to cover the cardio, respiratory, neuro, liver and renal function, skin, GI, and GU. So this is really important because we want to know the baseline of the patient that's about to have surgery, so that when they come out of surgery, we know what they should look like after. Neuro status, very important. Are they ANO times 1 or are they ANO times 3? Their skin, are they at higher risk for skin impairment? Do we need to take extra precautions in the OR to make sure that we don't give them, some type of wound? GI, were they constipated coming in? Do they have history of an ostomy? Are they continent? Do they have history of urinary retention? Liver and renal function, are their organs able to clear the medications that they're about to get? So all of those questions are based on their health assessment, their medical history, and also lab work that is done prior to the surgery. So some patient preparation. So I just mentioned labs. That may include a type and screen. That refers to possibly having blood available for that surgery. A complete metabolic panel, or CMP, that includes a BMP plus liver function. So basic metabolic panel plus a liver panel. Basic metabolic panel are electrolytes and renal function. So a CMP is everything. Coagulation studies, so that we can know what their bleeding times are to make sure that they're not at very high risk of bleeding out during the surgery. Complete blood count. This includes your white blood count and your red blood cells and your platelet count. So platelet count, again, that's one of our indicators of how well they're going to clot. And our red blood cells, we want to make sure they're not anemic. If they have a low hemoglobin hematocrit, then they may need blood during the surgery, or they may not be stable enough to even have the surgery. Generic urine analysis and a pregnancy test. So pregnancy test, if the female is found to be pregnant, then there needs to be a discussion made of the risk and benefit of whatever surgery that they're going to have. If it is an emergency surgery, they may go ahead and do it despite the pregnancy, or the patient has the choice to opt out, or maybe the surgeon doesn't want to do it. So there's a big discussion that has to be done. So that pregnancy test should be performed in the pre-op area, and the results need to be communicated to the physician. Radiological assessment, this will depend on the type of surgery the patient's having done. So if they're having a surgery done, to fix a fracture, then we need those x-rays. If they're having brain surgery, we're going to need that imaging to guide the procedure. Pictured here, we have a cardiac monitor, so the patient will be hooked up to an ECG, continuous cardiac monitoring, and that is standard. So this is also post-op, which we will find out later. Patient teaching. So patient teaching starts in the pre-op area. We are going to let them know what's going to happen, not only right before the surgery, but we want to tell them what they're going to wake up to after the surgery. Are they going to have an indwelling catheter when they wake up? Are they going to have an oxygen mask on or a nasal cannula? Are we going to ask them to use an incentive spirometer, stuff like that. So we want them to know a little bit about what's going to happen. Now, we don't want to give them a book of very detailed information because it can be overwhelming, especially in the pre-op area. They're nervous about what's about to happen. We don't want to, overwhelm them even more. So just the basic things on what to expect afterwards. DVT prophylaxis. Patients post-op are at higher risk of getting a blood clot, a DVT, because of the immobility and all of those medications. And of course, if they already have history of certain conditions, they're going to be at even a higher risk. So depending on the procedure, depending on the facility, and depending on the surgeon, you may be applying compression stockings. You may be putting on sequential compression devices, pictured here like the leg squeezers. So you want to get the patient prepped for that. You want to let the patient know mobility is so important. So, after surgery, when you wake up, we are going to walk, we're going to let you rest for 30 minutes and then we're going to get you up and walking. We want to prevent pneumonia. So when you're under anesthesia, everything relaxes. You're intubated, so there's a machine breathing for the patient. And, when there's machines doing what our body's supposed to do, our body just kind of gives up and lets the machines do it. So when you wake up, your body kind of needs to be, give a little push to start doing these things on their own again. So it's really important to cough and deep breathe, early ambulation, and to use that incentive spirometer. These are all things that you're going to be educating your patient in the pre-op area to do. Physical preparation. So we're going to talk about some of these things that may be required prior to the surgery or surgical procedure. So the patients will need an IV line inserted. A larger gauge catheter is preferred. Not only will this make it easier to infuse fluids, but just in case the patient is going to receive any type of blood product, we need a larger gauge IV. Bowel and bladder preparation. This will be determined by the surgery that the patient's going to have. Not everybody needs to do a bowel prep. Bowel prep includes emptying all of the bowels with some type of laxative. Pictured here, we have Go Lightly. That is one laxative that is used. Bladder preparation, again, this involves inserting an indwelling catheter, urinary catheter. This is placed when the patient is already asleep. This can be inserted if the surgery is going to be very long and we don't want the patient to have an incontinent episode, or this can be used to monitor the patient's intake and output. And this is something you, again, want to warn the patient might be still in place when they wake up. Skin preparation, this will include some type of chlorhexidine gluconate wash. And pictured here, I have chlorhexidine gluconate wipes, or CHG wipes for short. This may be done in the pre-op area and or may be given to the patient like the night before to do at home before the patient comes in. Whichever way your facility requires it, you just need to make sure that this was done. Medications. So in the pre-op area, the medications given might be standard and ordered by the surgeon. So for example, antibiotics. If the surgery requires prophylactic antibiotics, then you need to make sure that these are given at the specified time, which is usually 1 hour before the surgery time. And this is included on the preoperative checklist. Other medications that might be given could be related to the surgery itself. Like for example, if the patient is having a stomach surgery, then they may want to decrease the acid prior to the surgery. So they may get an infusion of some type of antacid. If the patient is anxious, they may be given something like lorazepam prior. Even if they're not anxious, sometimes the surgeon requires that just so that they can calm down and everything kind of rolls smoother. So also pictured here is a razor. So depending again on the type of surgery, you might be required to shave them prior. And an example of this would be a C-section, or again, anything where you have to access that pelvic area, or even on the arm, if the patient has a lot of hair, you may be required to shave them. And we use an electric razor, not a blade razor. A blade razor might have, it has more potential to nick the skin and cause more issues. So we use clippers for that. And we just want to make sure the patient has any ordered physical preparation prior. And if there is any reason why the patient did not receive that, like those antibiotics, then we need to alert the surgeon. Moving on to effective communication. Now, communicating with patients is important no matter what setting that you work in. So we're talking about the preoperative area. It's a very high stress environment for the patient. So we want to make sure the patient can understand what we're saying. So you want to avoid medical jargon, meaning don't use a lot of medical terms. Now, you also have to assess your patient's learning style. So maybe the patient is already in healthcare, maybe they're a physician, maybe they're a nurse, and they prefer the medical jargon. So you determine what is best for your patient. Too much information can be overwhelming, especially at that time. So you just want to give them the main priority information that they need to know. Your verbal and nonverbal communication is also important. You know, the way that you're standing, the way that you're presenting yourself. So always be self-aware. Active listening. You can never go wrong with active listening. Just listening to the patient's concerns can often put them at ease, and involve family. So family at the bedside, they're their support system. We want to make sure that they are also being given information and they feel comfortable also. Timeout, pause for a cause. So we're talking about the pre-op area. There's going to be another timeout that's going to happen in the operating room, but this one is kind of like a mini version, and this happens in the pre-op area with the surgeon coming out talking to the patient along with the RN witnessing this timeout happening. So during this timeout, we are going to make sure it's the correct patient. So the patient has to have a wristband with their patient identifiers on them, the correct procedure. So the surgeon is going to again have the patient state what they're having today, and then the surgeon confirms it, and the correct surgical site. And in this picture, you can see the surgeon is using a marker to mark on the patient's body. The patient agrees and the nurse witnessing this agrees, and you can see the nurse is holding a clipboard because she is documenting that this happened. So this is going to hopefully avoid errors once the patient goes into the OR. So here, for example, they're picturing the right wrist as the surgery site or the procedure site. Once they go in, hopefully everybody will see the markings on the right side and not do the surgery on the left side, which is the wrong side. So it's all about safety. And now we should be ready to transfer our patient out into the operating room. So prior to that transfer, we're going to make sure we have our preoperative checklist. Okay, we want to make sure those consents are completed, that the history and physical assessment has been done, that the patient has been educated, that any type of prep, physical prep has been completed that is related to the surgery, and that any preoperative medication has been administered. Of course, you are going to be following physician orders, and those orders will be very specific on when they should be given. I'm going to remind you that antibiotics should be given 1 hour prior to surgery. Not all surgeries get prophylactic antibiotics, but if you have one, it needs to be given 1 hour before. If there's any change in the scheduling of that surgery, then that medication needs to be adjusted to 1 hour before, whatever the new time is. And the next two slides are just a couple of images to help you visual learners. And that concludes this lecture.